attending this program. So Dr. Krishna Kumar, please.
Thank you. And my talk is on assessment of operability. It's a question that often is asked, and we still haven't resolved it after so many years of doing so much of experience that we've collected collectively. We haven't found a very precise answer. Topic will be covering some basic concepts and what methods we follow today, when do we do catheterization, and what are the tools we have of the various methods that we have. We have a number of tools, and what are the limitations of them. So this paradigm I have always been using, which is that there are four elements, which is the anatomy of the defect, the size, as well as the location, associated conditions like sometimes a stenotic valve or upper airway obstruction, and a number of influences that we don't fully understand, which are perhaps genetic, and of course, the age or the duration of exposure to high flow. There is a conceptual framework that everybody needs to understand, that pre-tricuspid shunt actually result in gradual increase in QP as RV accommodates and enlarges. And typical examples are ASD and PAPVC. TAPVC sometimes behaves this way, but TAPVC can also produce a disproportionate amount of PAH. So it's a slightly different situation, but most ASDs and PAPVCs, the pre-tricuspid shunt, the QPQS gradually increases. Whereas in post-tricuspid, there's a direct transmission of the pressure head because the shunt is between high pressure chambers. And as a result, you have a systolic transmission in VSD and systolic as well as diastolic transmission of pressures in PDA and APV. If you have pulmonary venous hypertension, increasingly it's obvious that it actually masks the whole picture. It may introduce an element of reversibility by protecting the pulmonary vasculature. And it's a concept that we in India have come to appreciate very well, but I don't think it is understood worldwide, and people are quite surprised as to how we take decisions in these patients. We are publishing this, but definitely if you have significant pulmonary venous hypertension, then all your rules do not apply until you've eliminated the pulmonary venous hypertension. If you have hypoxia, it tends to elevate pulmonary vascular resistance, and it can confound your assessment. And very important factor, especially diseases of pulmonary parenchyma, upper airway obstruction, and you can have a surprising elevation and degree of elevation in pulmonary venous hypertension, hypoventilation, high altitude. All these conditions can completely alter your assessment. Very important is the duration of exposure. So very, very significant factor. As you increase the duration of exposure, the likelihood of pvod increases, but the rate of rise is very variable and is determined by a number of influences. So if you take this kind of a framework that I have made, which is very approximate, and you take various lesions, you have a rough pattern that emerges. Of course, there are exceptions, and ASD tends to do reasonably well, and majority of them are operable even till very late in life. And those who are destined to become inoperable tend to actually do that relatively earlier than one would think, maybe in the second or third decade of life. A sinus venosus ASD is a little worse than an ASD. An unrestricted VSD or a PDA tends to be inoperable a little later than most other serious sinister conditions, but by second year of life, you would like to close all large VSDs, perhaps ideally by the first year of life. Truncus has a much more rapid progression towards PVOD, transposition with large VSD and PDA. You hardly would ever encounter somebody who's operable at the age of 4 or 5 years of age. So these rules are approximations. There is going to be a standard deviation around each of these curves, but by and large, they apply. Of course, there is a lot of variability. I've seen so many children with ASD that come with severe PAH, large ASD, large flow, yet also have severe PAH. We've had VSTs in a 3-month-old that looks like Eisenmenger and never reverses. I've had a 37-year-old with an operable AP window. We've all come across these fantastic examples. So we tend to remember them, and that makes it very difficult to predict in an individual patient. There is definitely a genetic influence that we really must study. And you have a bell-shaped curve when it comes to the risk of PVOD. At one end of the curve, you have this patients who are inoperable or remain operable no matter what happens, and though there are others that are very rapidly progressing. Perhaps we are looking at some examples of IPH at the very end of the spectrum. So the principles are very simple relatively simple for trying to distinguish between post-tricuspid and pre-tricuspid. The rule for post-tricuspid is if there is a significant shunt in the basal state, demonstrable in the basal state, irrespective of PA pressure, generally they are operable, particularly if this is a young child. As they get older, it becomes a little more difficult, but by and large, if you find large shunt demonstrable, whichever way you choose to demonstrate it, they are operable. Whereas in pre-tricuspid, any degree of pulmonary hypertension, even if it's more than mild, warrants concern. And especially if this is true, if the basal shunt is not obvious. So you have to be a little more wary of pulmonary hypertension in pre-tricuspid shunt because that is not so easily explained. Age is very, very important. So you give the benefit of doubt to younger people. A 1-year-old with VST and severe PAH where shunt is not so obvious, you may actually err towards operations. Whereas if you get an older child with a similar situation, your whole decision is going to be different. Lung, airway, ventilation issues are very, very important, and you have to take them not just during cardiac catheterization, but during all times of assessment. You take a Down syndrome with a VST and you put them after sedated echo, you might find a totally different set of hemodynamics on echo, and you might decide something altogether different. So you have to be respectful and mindful of that, as well as, of course, pulmonary venous hypertension that I talked about. Post-tricuspid shunts are generally operable. This is what I have said. And then, of course, sorry, I just moved ahead. So this is the paradigm that we all have when it comes to left to right shunt. It's an oversimplified paradigm that you have at one point things becoming inoperable and those becoming operable depending on the degree of damage to the pulmonary vasculature. In general, it's a gray zone. It's a spectrum, and you have a whole range of possibilities. And there is clearly operable patients where there's no doubt, younger patient with a large shunt, clearly inoperable patients, and lots of borderline. That's where we have to take a decision. So here's an example: child, large VST, and of course, completely left to right shunt, big X-ray. Nobody has any doubt. LA-LV enlarged. You would never catheterize this patient. Similarly, you have an Eisenmenger Frank with blue single loud S2. Nobody in India is going to catheterize this patient. Of course, the people in the West still catheterize because they don't encounter this frequently. And this comes in, if you look at their guidelines, they say you should catheterize these patients, but that's perhaps not indicated here. And of course, you see this echo, and you really don't waste time or resources on these patients unless they have a very specific issue that you have to address in the cath lab. So in the post-tricuspid shunt, those who are operable, largely you can make clinical decisions. You have failure to thrive precordial activity. So clinical evidence of a large shunt. And in the other extreme, you have cyanosis, quiet precordium, very absence of flow murmurs, typical X-ray with peripheral pruning, and to some extent ECG is helpful. So, obviously you have borderline patients who fall in the middle, and that gives you a lot of challenges in terms of deciding operable. Here's an example: a 10-year-old who was pink, was not blue, but had a large defect identified early in childhood, but wasn't operated, came to you and has this features of a loud P2. S2 seems to be split, but there is a murmur as well, but there is no evidence of mid-diastolic rumble. And this patient, just because he's quite old with a large shunt, you are inclined to try and get a better idea on this patient. X-ray, many of us would interpret it as increased pulmonary blood flow, but MPA shadow is prominent. The heart is somewhat enlarged. So this is all looking favorable. And you see the ECG, there are tiny Q waves, but there is persistent S wave suggesting there is right ventricular hypertrophy. And echo, I'm not able to play this film, shows bidirectional shunt. In this particular case, you're seeing predominantly left to right, but there was bidirectionality. So we take this patient and we can catheterize this patient to get a better sense of what the whole situation is, what's the QPQ is, what's the responsiveness to vasodilators, and then integrate that cath data with all this clinical data and then take a decision. That's the kind of way in which we've taken a decision in these patients. And believe me, that may not necessarily make you wiser or make you come to the correct decision, but just adds the quantum of information that you need when you have really doubtful cases, when you want more and more data to be very sure. So there are errors in cardiac catheterization. You have assumed oxygen saturation, assumed pulmonary venous saturations. If you don't enter them, the non-physiologic sedated state. And the calculated PVRI has not been standardized against the gold standard of long-term surgical outcome. No one has done that adequately, properly. And we should have done that. For some reason, we haven't done it yet. We should be doing it now, at least as a multi-center study. So in the real world, when you catheterize somebody, you convert borderline, you probably reduce the borderline zone. You still end up with a gray zone. You can't make it black and white by cardiac catheterization still, but you narrow the zone. And you have a spectrum of situations. You have PVR of ideally less than 4, you're very thrilled. Less than 6, you're perhaps okay, especially if the child is young. More than 8, you don't want to operate most of these patients. And you have the PVR SVR ratio of 0.3 or more than 0.5 for unfavorable situations. And believe me, basal data is far more important than anything else. The baseline data has the maximum value. You can try and give vasodilators, reduce the PA pressures, demonstrate a reduction in PA pressures by 20%, and you can feel a little happier about it, but this has not been validated against long-term outcome. So in cardiac catheterizations, thresholds are lower in AST than they are because clinical clues are less obvious. So if you have significant elevation of PA pressures, RVSP is greater than 50 or 60, then you need to do a cath. Deciding, this is an article that I have written quite some time ago, more than a decade ago. And believe me, not much has changed since then, I think. We've got a few more papers, but I would recommend this. It's in CAT CVI for the students, and we've integrated all these concepts and stated it. What else can be done in the cath lab? You can do test occlusion. There is little validation of long-term data with that, but with PDA we have a greater than 50% reduction in aortic systolic pressure would suggest that you can perhaps get a good long-term result by closing the PDA. So here's a 16-year-old boy with a huge duct, and it's very difficult to get the right QPQS in this patient, has no lower limb desaturation, systemic pressures. QPQS was calculated to be pretty low and PVR was extremely high, but then we found this nice reduction in PA pressure on balloon occlusion. So we went ahead and actually closed this PDA, and this patient did reasonably well, but we've had quite a few others with very similar data that haven't done so well. So to conclude, comprehensive clinical evaluation, X-ray, ECG, supplemented by echo, allows you to classify a vast majority of patients. In our experience, more than 95%, depending on the profile of patients that come to us. For us, it's mostly infants. And patients who are borderline, you need to do a cardiac catheterization, and you need to be very thorough and do a vasodilator testing. Even if it's of uncertain incremental value, it adds to the database and makes you more confident with your decisions. There is a value for test occlusion of PDA in selected cases, and perhaps that can be added on in those situations where you have a large PDA with borderline data. Thank you.
Thank you, Dr. Kumar. I think that was very simply put. And as you said, that there is such a lot of variability that it is difficult to take, blanket decisions, and you have to basically individualize. Okay.